Different fibers make contact with the muscles or entry point into the muscle, usually close to insertion. So in muscle there is different points of insertion, and distribution through facial sheath like epimysium, perimysium, endomysium, through the neuromuscular junction, and through the neuromuscular spindles and Golgi tendon organ. So we study for the Golgi tendon organ. Here we have to be clear about how the neuromuscular spindles work, how the Golgi tendon work. In this we see then another slide. In this slide the neuromuscular junction is showing. In neuromuscular junction, the motor neuron axon or the terminal axon, you see here the motor neuron axon under my cursor and axon terminal. So here is the synaptic vesicle containing acetylcholine. So acetylcholine is released by the motor neuron axon, and that just do the stimulation. So muscle end plate and acetylcholine will release, and that trigger or that circulate what the signals to the brain, and we perceive the pain. So neuromuscular junction is important from a practical point of view because it is the exact site where the trigger points are formed. So wherever is the this neuromuscular junction where the acetylcholine will work or motor neuron axons are meeting to the muscle or motor end plate of the muscle, there we found the trigger points. So this is the location site of the trigger points. And in the next slide what we see the fundamental difference between spindles and what Golgi organ can be summarized. So the neuromuscular spindles prevent excessive muscle stretching. So muscle stretching is the work of neuromuscular spindles, and the Golgi organ, what they will do, they will prevent the excessive muscle contraction. So where there is muscle contraction in an excessive way, there is a work of Golgi tendon organ. Myofascial pain syndrome. What is the myofascial pain syndrome? Defined as the presence of hypersensitive points called myofascial trigger points located in the muscle or connective tissue lining. They are called trigger points because these points cause pain not only where they are located, but they also shoot it in the area of topographical distance from the origin. So it's depend upon the communication which we studied yesterday, that what is the communication. So communication is like that when a trigger point is happened like on the trapezius upper fibers, it will be spread throughout the fiber. And in trigger points one thing is important, that trigger point never give you a specific pain. They may be spread throughout the muscle, they may be spread from one area to another area, so that we call reference area. So pain, joint limitation, stiffness are generally present because of the trigger point. This syndrome can trigger, for example, like problem with the clinical presentation typically of neck pain, back pain, or referred pain to the limb. Patient will come and say that I having neck pain, and they start complaining that I having referred pain to the limb. So they have pain from neck to the hand, they have pain from back to the legs. So this is called the referred pain. Next is what is the cause. So it may be set of traumas like repetitive injury to a particular muscle, or that is the whole set of situation capable of leading the formation of one or more trigger points, is represented by any stress that lead to an overload of the myofascial complex. So what happen, like people who are doing desk jobs, they are repetitively giving traumas to their muscle because they already have trigger point in their upper back, or they are doing the same posture, they are sitting on the same posture, and after that they having pain on that area. And trigger point are not like that. If one trigger point is there, it will persist like one only. It is changing, like initially there is one trigger point, after that muscle is not working, there is no circulation, so bad blood accumulation, and the surrounding fibers of that muscle also affected, and it will cause a spread of trigger points. So there are multiple trigger points in that muscle only, and that will give you pain, inflammation, and sometime it will restrict the motion. So people coming to you and they will say that they can't move their neck, they can't move their shoulder. One patient today, he came and asked me that I having pain in my shoulder, but he had an injury to the shoulder in past that is cured already, but now what he having pain on the trapezius, and he having trigger points at that area. So it will happen, like people they are saying that pain is there, but they have referred pain there because of that trigger point. So you have to be very careful while assessing the patient. Sign of the presence of trigger points can be many, not all present at the same time. Among the most important are the pain in the myofascial trigger point region and reference area, reduction range of motion, muscle stiffness, fatigue, limitation of both daily and sports activities, and the secondary pain, irradiation site can be enclosed in map that indicate advance what the myofascial trigger point of origin could be and on which myofascial structure it is located. So primarily it may be the trigger point which is on the trapezius, but secondary what is referred is from a different source, like patient having pain in the neck but the trigger point located near the scapular region. So it's a referred pain to the neck. He can't move the neck, he can't do the activities like flexion, so he having pain due to that trigger point. So it's a referred pain. What if we classify the trigger point in order to effectively treat the myofascial syndrome? It is necessary to be able to distinguish which trigger point to work on. According to their location, we have to treat the trigger point. Their activation status, we can classify them. Like there are classification, primary and the central trigger point. So what are the primary or central trigger point? The location itself and the pain and the activeness of that trigger point will say you what are the primary or central trigger points. Secondary or satellite trigger point, active trigger points, inactive trigger points, latent trigger points, widespread trigger points. So there are many of the trigger points. So we have to analyze first that what type of trigger point is there, and according to that trigger point we have to release that trigger point. We have techniques like manual techniques by which we can treat the trigger point. So primary or central trigger points, these are trigger points that are normally active and therefore manifest. They cause local pain and have a reference area that can also be identified through the appropriate maps. Maps are you can find on the Google also. So there is a appropriate maps where the trigger points are located. So we know the location, we know how to treat that, and we can treat it easily. Located in the heart of the muscle itself at the level of motor plate. So initially in the lecture what we studied that at the motor end plate the acetylcholine will release. And there are some studies which are saying that wherever there is a trigger point, the acetylcholine level of releasing is increased, and when it increase, it translate into the trigger points, because there will be more pain, there will be stiffness, there will be no movement of the muscle at that point, and it leads to painful trigger points. So treating them means resolving the symptoms. Like motor end plate, they are the real culprit of the painful situation, or we have to resolve them. So when we are just simplify, we are stretching, giving stretch to the muscle, or we are treating that muscle only. So we are not treating that pain, because we have to treat that primary or central trigger points. So we have to go to the end plate or motor plate, and we have to do the treatment. So it is the primary or central trigger points. Secondary trigger points or secondary satellite, as they can be inactive, not triggering a painful response. We almost always find them in area of pain reported by primary trigger. Treating these points give temporary relief, like from the symptoms. When treating a satellite trigger, it is necessary to apply little pressure, so it's not irritated, because we are not treating the main area. So we are treating where we patient feel pain, because he is giving us response. Then active trigger point, where trigger point activates, it become primary. So when a trigger point shows sign its presence, both in term of spontaneous pain on palpation, like when you are pressing over the upper trapezius, like mid of the clavicle, like not exact the clavicle, but forefinger above the clavicle, you find a trigger point in patient who are working on laptops. So what you can do, it can be defined as active, because when you are pressing it, it gives you pain. So secondary triggers can also become primary following their activation, which can happen after traumatic stimulus or overload of the muscle hosting a secondary trigger point. And the next one is inactive or latent trigger point. The definition of inactive indicates a state of consequence, typically of the secondary myofascial trigger points, which is also typical of sedentary, like person who don't doing any work, or they are not going for any activity, who does not practice physical activity any kind, or maintaining the same posture for a longer duration, like person who having sitting job for longer durations, patient who having like prolonged standing positions, they have to maintain the standing position. So they have these inactive or latent trigger point. Diffuse trigger points area in which there are multiple primary secondary trigger points, and which generally affect large muscle areas. So what are the role of inactive trigger points? Like they are not giving them pain for shorter duration, but after some time they feel pain, but they can't find the reason why they having pain. But the pain because of that trigger point, whenever there is trauma, whenever there is like muscle work, which is different from that, but the muscle is used by them is the same muscle, so they feel pain, and that become active trigger point for them. Next is the detection of myofascial trigger points. Like when we are detecting, we have to approach like that, that it is active, or it is secondary, or it's referred. So we have to analyze according to that. The trigger point pain map are essential in order to perform an optimal search for trigger points. So maps are very important, because they just give us idea when we are just pressing that points. So we have idea, and we can find that there is trigger point. So we have a map, and I will share you all. Attention is also paid to other signs that may occur in case of myofascial syndrome, such as joint stiffness or limitation. There are patients they don't have pain, but yes, they have stiff neck, and they have limitation of movements. So first we have to analyze whether muscle belly is soft or not. If muscle having some hard points or muscle having some trigger points, we have to first release those trigger points. After that they feel relaxed and muscle tightness will reduce. So the myofascial pain syndrome can have a sign and symptoms similar to many other problems that do not have a mechanical cause. It is therefore of fundamental importance that the treatment is carried out only after an accurate diagnosis, which has to be exclusively medical. So we have to be very careful, and as a physio we can't do medicines for that. We can release it by our manual techniques, and the myofascial release technique is the best approach towards these trigger points, and it will helpful for all. And for the next session, what we will do the myofascial release technique, and in that technique we will start from the cervical spine. So how to treat a trigger point, I will give you assessment and the practical thing. Thank you.